I'm grateful to Professor Sheikh for inviting me to talk on this very important topic, and I'm great to see worthy chairpersons over there. So let us begin. My topic is diabetes patient with cardiovascular disease already existing, who want to keep fast during Ramadan, how to manage them. So let us begin our talk. It's a very common condition to have coronary artery disease and cardiac problems in diabetic patients. In different studies,
لو سمحتوا يا جماعة معلش الصوت عشان بس نسمع وهو يعرف يتكلم ما نعملش انتربشن للسبيكر.
Thank you very much, Chairperson. Mr. Chairperson, thank you very much. So my topic today is patients with diabetes and cardiovascular disease. Can they take fast? And if yes, then what precaution they should take? Yes. Okay, shall I continue? It's okay, sir?
Yes, it's okay.
Hello?
Okay.
Okay, so these two conditions, they are quite common together. In different studies, we see 18%, 12%, and 10%. The 10% they are together. So we have to be more careful while dealing these two conditions. Now, IDF risk stratification. There are so many scoring plans, but here we see in macrovascular diseases, if it is unstable, then risk is 6.5%. But if it is stable, then only 2. And if there is no macrovascular disease, then 0. And what do we mean by this scoring? If there is low score, means 0, between 0 and 3, then fasting is safe. But they need medical education, medication adjustment with strict monitoring. If a scoring is between 3.5 to 6 points, means moderate risk, then probably fasting is not safe. But if they insist, then with proper evaluation and medical the drug adjustment and with more strict monitoring, they may keep fast but under strict supervision. If they are high risk, and we noted scoring for unstable cardiovascular disease was 6.5%, so they come in red color, very high risk. Then fasting is probably unsafe. It's not safe. So better they shouldn't be fast. But problem is this, whatever you say, whatever you insist, patient will say that no, sir, doctor, we will fast anyhow, whatever your suggestion is. So we cannot say that now it's your personal matter, do whatever you do. We have to give some guideline and let us see how we can do this. Before going into further detail, let us see some studies which have been done on these patients. So I have got 4 slides showing so many studies on this particular topic by so many wealthy authors from so many different Muslim countries. And strange enough, they show that in majority of them there was an insignificant influence result, not significant. In this study from Turkey, significant increase in ischemic stroke was more statistically. So this was significant, otherwise you see insignificant difference in these studies. This is my second slide on the same thing. Changes in cardiovascular risk in patients with type 2 diabetes. Now here you see there are so many parameters: fasting blood sugar, HbA1c, BMI, systolic and diastolic BP, triglyceride, LDL, HDL, and in most of them it is flat. In some studies, benefit. In some studies, benefit. But in other studies, increase risk. So there is no single conclusion. We cannot make a guideline from these studies. So we need more studies, more extensive studies to find out what should we do. There is no proper guideline exist for two diseases together. We divide them into stable and unstable cardiovascular disease. It's also weight up. So we have to be more specified in future for these guidelines. Now these are 2 slides regarding acute coronary syndrome patient with type 2 diabetes. They are keeping fast. So many studies again have been done, and again strange enough, no conclusion, no difference, not significant in most of them. Perhaps because they were more stable patients, this may be reason, inclusion criteria. And here you see in this study, strange enough, there was benefit in reduction of events of acute coronary syndrome. Maybe due to spiritual reason, stress hormone may be less. So in this study, there was a very benefit while keeping fast. Okay, so summary of evidence from cardiovascular outcome trials on oral hypoglycemic agents in these patients with type 2 diabetes and cardiovascular disease together. ECG, they are autologous LAD for precipitating heart failure. However, some studies like EPOS, Examine and Carmel didn't show this assessment. So, in advanced heart failure, New York classification 3 and 4, they are strictly contraindicated. No increase of heart failure when using GLP-1 receptor agonist. Rather, in many studies, they have shown cardiac benefit, so they may be given without any dose change, provided they are given alone. Then SGLT2, they are actually beneficial for reducing heart failure. And acarbose is the cardiac. They've got GI upsets very much, but as far as heart is concerned, they are safe. Sulfonylurea, if there is no cardiovascular problem, they may give. It is safe, second generation, latest generation, glyceride and glycoside. However, in these conditions, patients with cardiovascular disease together, they are very risky because of causing more hypos. But with changing time and changing dose, in certain group population, if they are stable, they will be tried. Dyslipidemia is quite common and it is due to our unhealthy food intake during Sahar and more carbohydrate, more saturated fat. So one must take care of dyslipidemia during Ramadan. Now let us speak cardiovascular disease and heart, why they become more sensitive. Actually, diabetes is a vascular disease. It is a metabolic disease because all metabolism, carbohydrate, protein, fat metabolism, electrolyte metabolism, water distribution, all are disturbed in diabetes. And finally, last but not least, it is inflammatory disease with accompanying dysglycemia. This is only part of manifestation. Actual problems are so many. And here is pathophysiological complication of atherosclerosis and hyperglycemia. So hyperglycemia will lead to AGE, advanced glycated and reticle formation, glucose autotoxication, then sorbitol PLC reduced base, endothelial dysfunction, leukocyte adhesions, more propagation. So it will lead to vascular complication, atherosclerosis, leading to cardiovascular disease. So how much risk of atherosclerosis? Life expectancy is reduced by 10 years if there is atherosclerosis. Mortality rate is high, 25% at 5 years and 75% at 15 years. 75% death are caused by heart attacks and strokes in diabetes. Number one. Then comes amputation, emphysema, and kidney failure, and some other complications. Now, how CAD is different in diabetes? And in Ramadan situation, fasting situation becomes more dangerous. Because atherosclerosis occurs at more younger age in diabetes. And it involves more than 1-2 vessels, mainly artery vessel disease. And it is more diffuse, it is not patchy, and even it involves periphery of the coronary arteries. So more difficult to revascularize. Surgery done, angioplasty may be more technically difficult, and result may not be as good as persons without diabetes. Worst outcome despite revascularization. Then increased least process and after PCI even with the stent. Then another problem, silent ischemia or myocardial infarction is common. Now pain is a blessing. If there is pain, patient rushes to cardiac hospital and seek advice. Streptokinase type injections can get rid of this complication. But if there is no pain, patient will simply develop arrhythmias and may die without even knowing that they've got heart problem. And women, they are blessed during fertile period from cardiac problem because of estrogen and X chromosome. So this benefit is gone if they develop diabetes during fertile period. Now this is very famous OSIS study. It has got so many graphs. Down graph, blue color is no diabetes, no cardiovascular disease, and these are the cardiovascular event rates. And red line is diabetes with cardiovascular disease, and you see many times increase in the cardiac events. Now this is very important slide. No diabetes, diabetes. No previous MR, previous FR. And you see at every stage, this is diabetes is causing more MR, 7 years than submyocardial infarction. So diabetes doubled the risk of MI mortality since beginning, despite advances in cardiac care. Now this was pre-1962 when only digoxin and diuretics were available. And this is update when we have got PCI and so many latest drugs available. But you see this blue color diabetes, it has got early mortality than normal population. So what are the diabetics with nephropathy right now? So So although they have got nephropathy, kidney problem, but eventually they die of cardiac problem. More MI, more heart failure, more strokes, and even sudden death, nephropathy leading to cardiac events and death. So they are mixed together. Now UKPDS, very famous study, 20-year study follow-up showed that 66% of patients with fetal MI had higher HbA1c than those with non-fetal MI. And these are my last 2-3 slides. All people with diabetes and pre-existing cardiovascular disease that are seeking to fast during Ramadan should receive a specific risk assessment first, which category they belong. And number 2, individualized, tailor-made advice. It is not general advice, it is individualized advice. Advice from not only diabetologist but cardiologist as well. Well in advance, about 3 months before beginning of Ramadan. Individualized advice based on the number 1 current health status. Okay, cardiovascular problem is there, but what is the current status? Is there any angina or some discomfort, dyspnea, chest pain? And how many drugs he is taking for cardiac problem and diabetes? So these 2 things count. Make a concentrated, to stay hydrated and get an adequate amount of sleep and nutrition before fasting. Individuals with diabetes, they have macrovascular complications such as stable or unstable cardiovascular disease or stroke should remain a category of high risk. They are at high risk. They are stable, unstable. These individuals generally should be discouraged from fasting. But the problem is this, patient, the doctor, whatever you say, we have to keep fast. So these are guidelines of those patients. Pre-diabetic assist is very important for diet, modified diet plan, especially carbohydrate, because we are in habit of taking more carbohydrate during Sahar and Iftar during Ramadan. And this is the reason our sugar becomes out of control and our body weight at the end of Ramadan, because it increases rather than decreases. Although we are taking theoretically 2 weeks rather than 3 weeks during fasting. And diabetic medications we adjusted. Now summary, fasting during Ramadan, despite the poor cardiovascular disease, does not increase hospitalization or worsening of underlying heart condition. Provided properly, care is given, dietary advice is given, and there should be modification of food, not only type of the drug, but timings of the drug and dosage of the drug. 3 things. However, further large effective researches are detailed in these particular patients with diabetes plus cardiovascular disease to carry any specific recommendation to the individual with diabetes mellitus and cardiovascular disease. Thank you very much.
Thank you very much, Professor Zaman Sheikh, for your elegant presentation. For the term stable cardiovascular disease, I have a presentation this afternoon, and I said that this is a misnomer because now there is no stable angina. This is chronic coronary syndrome, CCS, and there is no stability in heart failure patients because the heart failure patients with HFrEF can be stable for 3-4 days or 1 week, and after that he deteriorate and go to the hospital. So we have to change the term of stable coronary heart disease or stable cardiovascular disease because stability is a misnomer. Do you agree with this term or not?
Thank you. Very much. Actually, there is a lot of echo in the voice.
وقفوا الايكو بتاع if I okay, do you want me to repeat it again?
Actually, your voice is audible, but there is an echo in the voice.
now is good like that? Okay, I repeat it slowly. Stable cardiovascular disease is a misnomer. Do you hear me, Professor Zaman? في مشكلة.
I need earphones. Hello?
Do you hear me now?
A bit better, yeah.
Better? Okay.
Yes.
Okay.
Now.
The stability
Okay,
of
sir. Okay, sir.
stable cardiovascular disease is a misnomer, and because we have no patients with heart failure can be stable for example, for 1 week or 2 weeks. Hospitalization is common in HFrEF patients. Also, there is no stable angina according to the new guidelines. This is a chronic coronary syndrome because the rupture of the atheroma can reduce acute myocardial infarction in those patients. Why we still insist that those patients are stable while they are not?
Okay, sure.
Do you follow me?
I'm sorry. Can you repeat, please? Bit slow.
Okay.
Hello?
I hear you well, but you don't follow me, yes? I'm speaking about the stability of the cardiovascular disease. There is no stable cardiovascular disease. And you stated that stable cardiovascular disease have a low score, and patients with heart failure are in significant hospitalization during Ramadan. While this, this is a small study.
Yeah, yes, actually, the unstable 6.5 score and stable 2 score scoring system risk elevation. But I mentioned so many studies in which, because of lot of care, perhaps in those studies, that there were so many complications they were not seen actually. And many patients, they were hospitalized. Some studies have been done in hospitalized patients. And even in those, because of strict care of these patients, strict monitoring, strict medication change, and with the dieting factor, nutritional factor, there were no significant complications seen. So it is reassuring that theoretically, yes, there are so many complications, but then I showed 4 slides of so many studies. And in majority of them, there was no significant harm done to the patient in those patients with type 2 diabetes or type 1 diabetes even, along with cardiovascular disease. But this population will be different. In clinical practice, in general practice, we see different type of patients. And in this study, there are selected patients, excluding criteria, including criteria. So this is unnatural, artificial scenario in so many studies. But while sitting in clinic, we may see different type of patients. So we have to be more careful while dealing our patients in clinics.
Thank you very much, Professor Zaman. Any other questions from the floor? Okay, we appreciate your existence among us, and thank you very much for your presentation.